The ins and outs of post-treatment complications, particularly pertaining all of that, is probably best described to you by the people who do it all the time and are the experts. So I'm going to introduce to you David Gray, who is a nurse practitioner here at APCR. He is a urology nurse practitioner with special interests that include men's health, urological malignancies, particularly prostate cancer. Dave completed his Masters of Nursing in Urology and Incontinence through La Trobe Uni in 2012 and completed his Masters of Nursing Nurse Practitioner through Flinders Uni in 2016. Dave is a hopelessly addicted golf tragic. It's better than football. So over to you, Dave. Thank you very much.
Today, I guess, or tonight, I'll talk a little bit about what we do in our centre, and we're very lucky. We're very well resourced compared to a lot of other centres too, but I think what we do through here is very translatable to, I think, what you as GPs can do, and also your practice nurses as well. So we'll talk about urinary incontinence post-treatment, urinary function issues post stricture and retention, and then erectile dysfunction as well. And even though I haven't put it up as a point, also talking about, I guess, the psychological state of the patient throughout this trajectory. And I think when you start to get points 1, 2 and 3 correct, and I guess on the right path of improvement, then I think the patient's psychological state will also start to turn the right way as well. I think it's a nice segue of all the talks tonight, with Anita talking about the very start, Homi talking about definitive treatment, and then coming back into GP practice as well. So urinary incontinence is probably one of the biggest and most bothersome things for patients. So a lot of the times the triad that was mentioned as well is of wanting to be cancer-free, potent, or incontinent as well. Sorry, probably continence is probably one of the most important things. So the main type of leakage that a lot of the men are going to experience after having surgery will be stress incontinence. So anytime there's increased abdominal pressure on the abdomen causing a flush of urine to come out. So urge incontinence can also be experienced by some of the patients where they, after they have had surgery, they will have this urge to really get to the toilet, not always be able to hold on as well. A lot of patients won't typically leak overnight because there's no abdominal pressure on them. And how do we monitor how much they're leaking? So it's with a pad weight diary. Some patients might be using 2 pads a day, which sounds good, but then if you ask them what type of a pad it is, it's an incredibly heavy pad, which might be holding 600 or 800 mils. So weighing that pad is important because you actually quantify how much urine is actually being leaked, whereas if a patient's changing their pad 7 or 8 times a day, it might be a very small, thin pad, but they're still using the same amount. So always, I guess, a pad weight diary is one of the most important things. And then the devices that are used as well. So pads are the most common thing. A lot of men will generally get pad free, and a lot of men will use one pad, a very light pad like a panty liner, purely as a security, but they are still pretty dry. Like Homi mentioned, about 5% of men are probably going to require some form of extra treatment further down the track, but that then also gets them to a very dry stage as well. I've put up penile clamps, which isn't a form of torture. In the right patient, it is used quite well. And for any little bits of leaking or drips that do happen in the right patient, it can work. And condom drainage as well. We don't really advocate it too much, but again, in the right patient, it's for someone who has uncontrollably leaking urine. They don't retain any urinary function at all, and if they have excoriated skin from wearing pads or something, they can use condom drainage for a bit of to give their skin a bit of a rest or a break. Your patients might ask, where are you going to buy these pads from? We typically send everyone to Independence Australia, so they're a not-for-profit group. Showroom is down in West Footscray, very competitive with their prices, and they also have a continence advisor there as well. So you might have a patient who is using one type of a pad, but it's too expensive, so they can call the advisor and find out more about it. So anything to do with they sell. So pads, condom drainage, catheters, things like that. On every other corner, there's a Chemist Warehouse. Chemist Warehouse are incredibly competitive with their pads as well. They move through so much stock that they sell a lot of pads at really cheap prices, and they have appropriate pads for men too. And supermarkets as well. So that's the other thing, that where pads are available, but they're typically a little bit more expensive. The question of, I guess, identifying this with your patient as well is, how is your urinary function, or are you leaking after surgery? If so, how much are you leaking? They're two really important things to be able to bring up the topic and make sure that that it's been addressed, and then you working out with the patient how you're going to best sort that out. Like I said, we're very resource rich here. All of our patients pre and post surgery will meet with a pelvic floor physiotherapist who'll be teaching them how to do how to contract their pelvic floor correctly using an ultrasound device as well. So they get really good feedback on how to do that. So if, I guess in primary practice, if someone is coming back to you and they are really struggling with these changes post-treatment, like Anita said, we tell all men that they are going to leak for around about 12 months, and as time goes on it should get less and less, and then if it is still after 12 months, then a referral back, if they are already in your care, then probably looking at wanting to chat to a urologist to discuss what some of the surgical management might be, because it is important for their quality of life that they do become dry. We use a team care arrangement for our physiotherapy services and allied health services through here. So prostate cancer being a chronic disease is then enabled in the chronic disease management plan, which is 5 subsidised free appointments. So it's very important to utilise that. The changes, sorry, I'm jumping around here. The changes in urinary function, like I mentioned, is the worsening of the incontinence. Hematuria, so should always be generally warranted, particularly in men, with a referral to a urology. And also if the patient's complaining of slow flow, that really does start to potentially be an alarm bell because of instrumentation and catheters, whether there might be a stricture or something through there. And it's definitely not to badmouth the radiation oncologists, our colleagues, but there are patients that we see now from maybe 10 or 15 years ago that did have radiotherapy that have just really terrible bladders, and some of them will have either ongoing hematuria that might require hyperbaric therapy treatment, or even having to even have their bladder out as a diversion purely because their bladder capacity is so poor, or they do continue to bleed. So it's a harsh reality. It does happen, but luckily radiotherapy techniques are getting much better as well. After surgery, particularly with a bore out or a TURP, it can take bladders quite a while to settle down as well. So I wouldn't be rushing too quickly into prescribing an anticholinergic or Betmega or something along those lines. Patients really need to have a little bit of time for their bladder to settle down. Stricture as well, so that complaining of a slow flow, whether there is a narrowing in there, it is just going to put more pressure on the bladder and then involve the upper tracts as well and look at potentially damaging them too. And not voiding at all, urinary retention is a medical emergency, so straight on to there. So erectile dysfunction. You can see here on the left was a flaccid penis, which doesn't really need any explanation, nor does the erect penis on the right. So it's the tissue that lines either side of the penis that engorges with blood and then basically shuts off the valves for any venous return blood, which is what maintains the erection. And there's a triad. There's lots of triads in urology. So the triad for an erection is you need a good blood supply, you need a good nerve supply, and a good psychological state. So if a patient is, and I guess this is from the non-prostate cancer patient and a prostate cancer patient, if they're very much well overweight and potentially depressed, already they've probably got a poor blood supply and their psychological state might not be in the best place. So 2 of those 3 of the triad aren't working. Their nerves might still be there, although and intact. Whereas someone who's had surgery, their blood supply and potentially their nerve supply might also be compromised. So this is, I guess, key for wanting to find out why a patient might be getting erectile dysfunction. And how do we manage it? So there's the 5 Ps. There's the psyche, the pills, the pumps, the pricks and the prostheses. When we're chatting to a patient, the psyche is one of the, I guess, important things, particularly post-prostate cancer treatment, is the patients really need to know that what they're experiencing is normal, and also the education. If their erections weren't good before surgery, they're not going to get any better, and it's important that they know that too. Patients who do have poor erections before surgery generally do poorer than those who have good erections before surgery, and for radiotherapy too. So the pills we talk of, this is pre-treatment and post-treatment for what we call penile rehabilitation or prehabilitation. So Cialis on demand is whenever you need it at 20 milligrams. Our patients pre-surgery and post-surgery, we get them to take 5 milligrams daily. And they don't necessarily need to be sexually active, although it does help with trying to preserve their penile function. And then with Viagra as well. So a 25 milligram tablet 6 times a week, but then on the 7th day having a 100 milligram tablet as well for nighttime, just for helping, I guess, it work in the background. And then there's the pumps. So pumps are important, and it's, I guess, going back to the very start, is making sure that your patient gives consent and feels comfortable for actually wanting to talk about some of these things. You can make a patient feel incredibly unwell if you really dive into it without actually gaining their consent of wanting to know, or for them to actually discuss this as well. So pumps work by basically as a vacuum device and bringing in venous blood. So a patient ends up with basically a cold or a colder penis, and then using a constriction ring. And that can work well for patients who might get a half erection or a grade 2 erection. They can use a pump and a ring just to help, I guess, get them a harder erection. And then there's the prick. So when you start talking to a patient about injections into their penis, their knees start knocking, and they're generally not too keen on something like this. When you actually show them, and what we do here with our patients is a lot of consulting. So it's generally 1 or 2 appointments where they're educated on how to do it, and then maybe on the 2nd or 3rd appointment, the patient actually comes in, we've got some samples, we'll actually watch the patient inject themselves. So they get the idea. We do it with a very low dose, about 2.5 micrograms of Cavaject in this case, and generally it's not enough for the patient to get an erection, but then we then empower them to titrate their dose depending on the grade of their erection. We start at the lowest dose because of the risk of priapism, which is why I guess now that a lot of the AMI clinics don't exist, because men were just getting injections, going off and getting maximum doses and then presenting to an emergency department with a penis that's been erect for beyond a day in some cases. So we make sure that we educate our patients in regards to getting some pseudoephedrine to help with if they do end up with priapism, just to try and reduce that. So we get them to take 2 tablets of 60 milligrams, immediate release, go and do some exercise, go and get an ice pack. If they've still got issues after 2 hours, then it's another 2 tablets. And if it's still erect after 4 hours, then they're off to the ED, generally to get it drained. By that stage, there's potentially a bit of fibrosis, and the patients might suffer from long-term erectile dysfunction from there. Then on the surgical side of things, prostheses. So it's like a robotic penis, really. So good for a man who really wants to be able to get an erection spontaneously and on demand. So there's a little, I'm not sure if my cursor will work here, but you can see in the scrotum there's a little activator that has basically pumps, and it pumps fluid from a reservoir that sits low in the abdomen into the penis, into the chambers on the side. So that there is a way that a patient can get an erection straight away, generally in hospital for a couple of days, and they can't use it for quite a few weeks afterwards. But then once it's in, quite a low rate of sepsis. Some patients may almost need to have them changed over after a few years, not necessarily from wearing them out, but from generally their in-body life would be about 10 to 15 years, Homi. So another option. Unfortunately, through the public system, patients would wait quite a long time. The Royal Melbourne might put 1 or 2 in, maybe a year. Same with some of the other public hospitals around town. A lot of patients would, if they're very keen on it, would get private health insurance for 12 months, wait out the wait period, and then look at getting it subsidised through there. So I guess in private practice, or in public practice I should say, or primary practice, the nurses, if you have them, I think patients are a lot more willing to talk to us and tell us a lot of their difficulties rather than with the GPs, and particularly with the urologist. It's amazing how much information as a nurse we can extract from a patient, and then the urologist will come and say, how did you know that? And it's because we have the time to talk to them. I won't say that we're more caring, we might appear that way, but they're always happy to talk to us. And I think when a patient starts to improve their urinary function and then their erectile function or sexual function starts to return, I think then psychologically they benefit as well. From a sexual function point of view as well, it's hard if there's time constraints. You can't always talk about purely penetrative side of things, and that's when I guess it's sometimes getting ready to refer on to a specialist, a sexual health specialist or counsellor that's going to be able to help with some of that as well. So hopefully that's a brief snapshot of what can be addressed in private health, or in primary health, sorry, and how we manage it through here as well. So I had a slide for questions, but I know it's not until the end. So, Anita.